One of my disclosures, number one, most of my PCIs I do radially. So the debate is really not whether it's radial first, because I'll give you that. The radial first, I think, is the way to go. Radial first and radial for 100%, or radial first but femoral has a role. Here I think we can debate. Facts and common sense, that's what I'm going to use for my arguments. So as you've shown, this nice study, we've demonstrated there's clearly an uptake of radial PCI in the US, both in the stable and STEMI population. And the question is, where should we peak? Should this really be at 100%, or should we be happy with 70 to 80% or so? So let's look at a few benefits that already were mentioned. There's no question when you look at large meta-analysis that the bleeding and vascular complications are reduced in favor of radial access. And we can debate that perhaps vascular complications are rare and perhaps it's mostly preventing hematomas and pseudoaneurysms, but no question there is less vascular complications. When you look at the opposite side, there's a little bit more of a procedure failure with radial, although that can be overcome with technique. But where do we see femoral that it still has a role? Well, number one, failed radial approach, radial spasms, AV fistulas, although you can go to the contralateral side, bilateral IMAs, and let's not forget about large bore access, both for complex PCI, 7 French, 8 French PCIs, but also mechanical support and endovascular procedures and TAVRs. So we need to remember that we still need our femoral experience. And what about patient preference? Well, we all think that patients prefer radial, it's more convenient. But what patients really prefer is going home early. Length of stay in this survey was the most important thing for the patient. Access site, as a matter of fact, was the least important, but if you can get them home sooner with radial, that's the way to go. Let's talk about radial artery occlusion. So on average, if you look at the aggregate data, 8% radial occlusion within 30 days, about 5% late occlusion. Is it important? Well, most of it is asymptomatic. When you look at femoral versus non-femoral radial, complaints are usually kind of similar, 20% of the population. But when you look a little bit closer and you do kind of a sensitivity measurements after the radial procedures, what you see that after radial occlusions, indeed, you have diminished sensitivity in those who have radial occlusion present. But not only that, even if you look at the transradial access versus contralateral access, there is some diminution of the sensitivity after radial procedures. Is that important? Well, not in everyone, but if you have occupation like interventional cardiologist or a musician, then you want to consider thinking about radial versus femoral. How about crossover? Well, 7% you showed in SAFE PCI trial, there was about 6% crossover. And you can cross over, of course, to contralateral side, snuff box, ulnar. But if you're doing a shock patient or a STEMI patient, you got to go quickly. So femoral may be the way to cross over. And here is a review that was very nicely demonstrated by Sunil and others that deals with complex PCI. Of course, complex PCI can be and should be done with radial frequently, but sometimes you need complex techniques like bifurcation with SKS, multiple CTO guide, circulatory support. So if you need a more than 8 French guide, you got to go femoral. If 7 French or more, then you can look at the femoral, at the size of the radial artery and decide if you can accommodate radial approach. And here is a study retrospective of left main unprotected PCI radial versus femoral. Certainly you can do it, and certainly you can get similar results between femoral and radial. But what's interesting to me is that when you go radial, your strategy changes a bit. You use more often less size of a guide. You use one stent strategy more often, less IVUS, less balloon pump. So your strategy is changing, and I think it should be the other way around. You should design your strategy the way you want to treat your patient and your lesion, and then decide on the access. How about renal disease? Well, this one is open for discussion. I don't think we have much data. There are small studies that show that, yes, it can be safe. But I think we do need trials, and we do need to think about our dialysis or pre-dialysis patients a little bit more carefully. Shock patients? Well, shock, certainly even in Europe, still under 50% is performed radially. Can you do it? Yes. But not always. It's difficult. So here you still have a large role for femoral. Let's talk about STEMIs a little bit more. So I think I agree with most of the arguments that were made. STEMI is the perfect situation where you get benefit from the bleeding, vascular complication, renal protection, length of stay is shorter, patient comfort, and potentially even mortality. The mortality, I think we do need to discuss a little bit further. I think in STEMI, most of the mortality was driven by the RIFLE and RIVAL trials, and those two were subgroups of the large trials. They weren't STEMI population trials. And if you look, I think, as you mentioned, as Sunil rightfully mentioned, the etiology of death is questionable because the bleeding rates, for instance, in RIVAL were similar, but the STEMI mortality in the radial group versus femoral was quite different. But even though we don't understand why the mortality, Safari STEMI perhaps is the trial that was supposed to get us to the point of why and is there a difference in mortality. And it was mentioned already, yes, the trial was stopped early, but what was interesting is we saw very low rates of mortality at 30 days with both groups. And not only that, what was surprising is that we saw very low rates of bleeding at 30 days. So if you are a skillful interventionalist, whether you do it femorally or radially, you can get very good outcomes. And the last thing I'll say is the radial paradox that people have been talking about. Well, are your skills diminishing if you're doing mostly radial PCI? So here is a study in Canada that was performed looking at the historical cohort, which was mostly femoral, versus after they switched to mostly a radial approach. And what they noted is their vascular access complications stayed about the same, and they stayed the same because the radial complications went down, but the femoral complications went up. And that's what we want to prevent. And actually, it's not just retrospective studies. If you look at the trials, Matrix kind of hinted at that. If you look at the group that was done by very experienced operators, more than 80% doing radials, you can see that the femoral complications are higher than in the rest of the groups. So here's what I would say. The complexity of PCI has been increasing over time. Our group and many others have shown that. We're doing more complex cases and patients through femoral approach. And we're treating and we're training less femoral. So is it surprising that we're going to have an increase in femoral complications when operators are doing primarily radial? Well, it depends who the radialists are. If you have trained femoralists who have converted, and I think Sunil and myself are in this group, that may not affect you that much. If you have trained radialists who are doing structural and large bore access, that may not affect you too much. But this is where the paradox might affect you a lot. If you train radially and you're doing mostly radial, when you need to go femoral, that's where experience may hurt you a little bit. So facts and common sense. Radial first, absolutely. Most patients should have radial access, fewer bleeding, vascular complication, but clearly there are patients for whom femoral access is more appropriate. But you need to do it right. You need femoral access that's safe, ultrasound-guided, micropuncture, vascular closure devices, and if you do that, you can get very good outcomes even in STEMI population. So, radial first, but femoral has a role. Just follow the facts and common sense, and if you do 80% radial and 20% femoral, you'll make both radialists and femoralists happy. Nice. Thank you.